In this webinar, we hear from ophthalmologist Dr Niall Aboud on how not to be blind to diabetic retinopathy. Niall will explain how OCT has revolutionised the detection of early diabetic retinopathy and when you need to start screening in your own diabetic patients. Learn about laser and injectable options and what the pros and cons are for each treatment. And be reminded about the need to be careful in making aggressive blood sugar changes if there is underlying retinopathy. Good evening. Welcome to tonight's Nordocs webinar, Don't Be Blind to Diabetic Retinopathy. My name is Peter SIlberberg and I'm a GP at Lennox Head Medical Centre and at the Aboriginal Medical Service Rekilling the Health Spirit in Lismore, and I'll be your facilitator for tonight's webinar. Just a reminder that Nordocs is a network of all doctors, including GPs, specialists, doctors in training, including medical students living or working in our footprint that extends from the Queensland border to Grafton, and our aims are to support all its members by improving health of our North Coast community. Education is a big part of this process, including these webinars, our flagship quarterly magazine, and we very much hope at some stage a return to face-to-face teaching. I'd also like to make a special mention tonight to any optometrists and diabetic nurses and practitioners attending tonight's meeting. An acknowledgement of country. I'd like to acknowledge the traditional owners of the land in which we meet today, of the Bundjalung Nation, and pay my respects to elders past, present and emerging, and to any Aboriginal people attending tonight's event. The Bundjalung Nation extends from Grafton on the Clarence River to the south, to the Logan River in the north, and inland as far as the Great Dividing Range at Tenterfield. I'd like to thank our sponsors for tonight's event, Ballina Day Surgery. Nordocs is a not-for-profit organisation and relies on sponsorship to run these education events for its members. Thank you, Ballina Day Surgery. And I'd especially like to extend a warm welcome to our presenter tonight, Dr Niall Aboud, who's coming on. There he is. And we'll just get you to unmute, Niall.
Hello.
Hello. Welcome, Niall. So thank you so much for coming along tonight and spending the time to prepare this talk for us. Just before we get started, so the audience can get to know you briefly, can you just tell us a few things about yourself? Maybe start with by how it is that you ended up living up here on the North Coast.
Yeah, thanks, Peter. Thanks for inviting me. I came 22 years ago. I think I was in the UK and I answered an ad, and I trained in Brisbane. I'd never really come further south than Byron Bay before, so I wound up living in Lennox Head, and yeah, practiced here ever since.
Never looked back.
Never looked back.
Fantastic. And tell us a little bit about why you decided to become an ophthalmologist.
Well, yeah, my dad's an eye specialist. So when I was born, he was training at Sydney Eye with a 2-year-old, and then I was born. And similarly, I came and I had a 2-year-old, and my wife was pregnant with my second child too. So it's this history just repeating itself, it seems. Yeah.
Yeah, right, okay. So everyone knows, tell us where you're working at present, Niall, and your scope of practice.
Yeah, well, I'm based in Lismore and Ballina. So I'm opposite St. Vincent's in Lismore, 11 Daly Street, and in the ground floor Ballina Day Surgery. So I operate at both those places privately, and I'm at the base too. So I operated the base yesterday. And yeah, I'm a general ophthalmologist, so I do lots of cataracts, glaucoma, oculoplastics, medical retina. Yeah.
Fantastic. Well, as a GP, and I'm sure lots of other people on the webinar tonight extend a warm welcome. It's great to have local specialists to come and talk to us and put a face to the person that we're referring to. And I know that you're always very approachable and easy to get hold of. So thanks for coming along. Now, as we move along for tonight's event, you will have the opportunity to ask questions. So at the bottom of your screen, if you put your cursor there, you'll see a chat box. So there is a Q&A box, but we'd prefer to use the chat box if that's okay, just so we've got it all in one place. And we do like these to be interactive, so if you have a question as we're talking, then put one in there and we'll do our best to get to it. All right, so these are the learning outcomes for tonight. So by the end of the hour, we hope that you'll understand the importance of screening and treating diabetic retinopathy to prevent blindness. I'm sure most of you already have a good grasp of that. That will be strengthened. We hope you'll feel confident in utilising the most current screening guidelines around this topic. We'd really hope that you can understand how optical coherence tomography, or OCT, has revolutionised early detection of diabetic retinopathy, and we'll spend a bit of time looking at what that looks like and how that's performed. We want you to understand the pros and the cons of new diabetic retinopathy medication, anti-VEGF group of medication injections compared to traditional laser treatment for diabetic retinopathy. And we certainly want you to feel confident to be able to discussing this topic with your patients when they're in the room with you. So we all know that diabetic retinopathy is an important risk in diabetes, and we all know that it's treatable. So Niall, tell us why is the role of the GP so important for this illness?
Well, I think, crucially, management of blood sugar and management of the risk factors is obviously crucial. But I think now, I think with these new modalities of treatment and new methods of investigation, I think that the crucial nature, I think, of the fact that the treatments now are so readily available and quite successful, the obstacles, I think, to managing diabetic retinopathy is just failure or obstacles to seeking treatment, coming for screening, being monitored sort of at appropriate times. And that's where I think it involves all of us, I think, in sort of ensuring that patients are sort of well screened and monitored and managed.
Yeah, very, very much a multidisciplinary approach between the GPs, you and the optometrists and the diabetic nurses and practitioners to make sure this is happening. And got a good case at the end of this talk that a patient of mine that shows what happens when, things go wrong when this is missed. So that's good. And then I know there's quite a new paradigms, we've called this, in treating diabetic retinopathy. So tell us what these are over the last few years that are really changing how things are done.
Well, certainly you're well aware, I think, of the increasing, prevalence of type 2 diabetes in society, related to obesity and diet. But you're probably not aware that coupled with that is possibly a decreasing incidence of diabetic retinopathy due to improvements in medical control of blood sugar with new medications and more intensive monitoring, more intensive treatment. So I think you're probably not aware that thanks to tightening of blood sugar control, diabetic retinopathy is becoming probably less prevalent. But that's countered by the fact that there's an increasing prevalence of diabetes in society. The other paradigm, I think, traditionally, fundus photography formed the basis for screening and classification of diabetic retinopathy, but we tend to that gives you an ability to look at the retina sort of on fast. But we are probably more interested in the effects of exudation and leak. So we use another tool now regularly. Almost all our diabetic patients, we sort of check with what's called an OCT. So that gives us an indication of leak, and that has major implications for vision. So that perhaps is a new modality, which is tending to replace or complement rather fundus photography and fluorescein angiogram, which is a traditional method of checking for leak.
And it's probably worth saying there that many optometrists have access to these machines now too.
That's right. So it's very common amongst the optometrists to have these machines in the local community. The increasing role of anti-VEGF, which are agents injected into the eye, as opposed to the traditional methods of laser, vitrectomy surgery for proliferative diabetic retinopathy and vitreous hemorrhage. So that's a change, I think, in treatment. We've now got, and the shift is now to find longer acting agents. So traditional agents, anti-VEGF agents, have a half-life of a month or 2 months, and there's now depot methods of delivery which might give us 6 or 12 months of effect. So that's an interesting advance. And part and parcel, I think, of the screening process. I think we are now utilizing optometry, and particularly in outreach settings where I think medical facilities are sparse. We're utilizing screening by optometrists and clinical nurses. And there was some proposal put out recently by a Medicare review that perhaps trained nurses could be trained in the ability to give intravitreal injections like they do in the UK. So that might be something that is done in the future, but it's not done now currently, and hence the thinking of using telemedicine in the absence of ophthalmologists. The potential for using AI to screen for diabetic retinopathy too.
Well, that's a great summary, and so we're going to start going through those things in a bit more detail now to elaborate and give people opportunity to ask questions. So this is a slide that highlights at the top the major risk factors, and then over time what happens inside the body, which can lead to diabetic edema and retinopathy at the bottom, which is the red box. So I was just having a look at this again today, Niall, and I think that point you made earlier about tighter blood sugar control and tighter control of other risk factors is reducing the prevalence of diabetic retinopathy in diabetics is highlighted at the top of that chart. So, if GPs are better controlling blood pressure, blood sugar, cholesterol, then you're preventing this from a very top-down approach. So you don't end up down with the reactive oxygen species in that yellow box, and eventually the green box, which is some of the stuff that leads to some of the damage. So I think that emphasises that point you made. But the other point that we talked about is in that box, in that diagram, where do the VEGF agents fit in, and where does the traditional laser treatments fit in?
It's a very old slide, but the first of all, the laser. So the laser effectively acts on the retina to reduce the, so we tend to obliterate ischemic retina. So you're reducing that ischemic stimulus, hypoxia. So we're reducing factors associated with hypoxia. And the anti-VEGF agents similarly have an effect on, it's produced in ischemic retina. So I think the effect of the anti-VEGF factors is included in that fairly short list of cytokines and chemokines as one of the byproducts of hypoxic retina. But there is a role for inflammatory mediators as well. And I think that's where, so there's a depot steroid injection too, which is found to be beneficial, and it's reducing inflammatory mediators in diseased retina. So I think it's, so I included the slide because I wanted to just give you an overview, I think, of the basic pathophysiology, but to also include the effects of hypoxia and inflammation, and they're also exacerbated by the dyslipidemia, hypertension, as well as the hypoglycemia. So yeah, it's multifactorial.
Oh, yeah. So, and then, the next slide was prompted by me just to ask you the question, patients with diabetic retinopathy, how may they present to us as GPs or to optometrists, diabetic nurses?
Yeah, well, I think the thing to realise is that loss of vision is the indicator that there's an element of diabetic retinopathy present. Naturally, there are multiple causes of loss of vision, and it's not always related to diabetes at all. But diabetes can have an effect on the eye in multiple ways. Diabetic retinopathy would be the commonest and has been proven to be the commonest cause of vision loss in diabetes. But there are other possibilities that need to be ascertained. And I think corneal epithelial disease can arise secondary to the diabetes, and I think in corneal stroma, loss of endothelium, which is the inner layer of the cornea, is a result of diabetes. You're very familiar with cataract as being secondary to diabetes. There's a reversible type cataract in high blood sugar, which can potentially reverse with control of the blood sugar. More commonly, posterior subcapsular cataracts we see with diabetics. Rubiosis iridis, you may not be familiar with the term, but that's a neovascularization of the iris, which could lead to raised pressure and glaucoma. Other causes of vision loss are retinal detachment, traction by new vessels at the retinal level, vitreous hemorrhage. Diabetes can affect the delicate circulation of the optic nerve, leading to a ischemic optic neuropathy, which is non-arteritic, not secondary to giant cell arteritis. And diabetic papillopathy, which is a swollen disc, often bilateral, associated with severe and prolonged raised blood sugar, seen less commonly these days, but it's in the books. Yeah.
Amazing how many things can go wrong with your eye with diabetes. Certainly not the friend. Diabetes is no friend of the eye.
Yeah.
So we'll just go on to the next slide. So this is a grading of or traditional grading of diabetic retinopathy. And it's got some acronyms in there that we often see in your letters, like the PDR and the NDPR. So, tell us. Yeah, I mean, some people may have remembered seeing these slides before. We thought it'd be worth just going over them again. So, just talk us through we're looking at here.
Okay. So these are the classic classification of diabetic retinopathy that was derived from the original very big studies 20 years ago to classify diabetic retinopathy. And so there's two. So I've got a set of three up the top and a set of three down the bottom, and the three up the top are early stages, and they are not necessarily requiring treatment. So they're reversible with good blood sugar control. So the classification on the left, it's quite simple. Non-proliferative diabetic retinopathy, which is the top three, and proliferative diabetic retinopathy, which encompasses those lower three. Traditionally, or in the past, it was referred to as background retinopathy. That term is not classically correct, but it's either mild, moderate, or severe non-proliferative diabetic retinopathy. And mild is just microaneurysms in less than 4 quadrants. Moderate is microaneurysms in all 4 quadrants. And severe is microaneurysms in all 4 quadrants, hemorrhages, venous beading in greater than 1 quadrant, and intraretinal microvascular anomalies, which are not new vessels, they're flat, abnormal vessels, but they're flat to the retina. And then we go on to proliferative diabetic retinopathy, PDR, which is quite simply new vessels which leak fluid and blood present at the disc, NVD, new vessels at the disc, or elsewhere, NVE, new vessels elsewhere. And associated with that is hemorrhage in the vitreous or in front of the retina, pre-retinal. And then in severe advanced cases, you wind up like you do on the bottom right of the screen, as far as the pictures go, with tractional retinal detachment. So that's the classification that derived from the big studies tradition.
So we do have a question about in proliferative diabetic retinopathy, when it's with centrally involved edema, what treatment do you do first? But I think we're going to get to that. So we might just hold off on that question for a second for that person. So we'll just go to the next slide, because this is what's changing things. Here's an OCT machine. So and you're saying in many ways this has revolutionised early detection of disease. So yeah, tell us why.
OCT is I'll tell you how it works. Is it shoots near infrared light at the retina, so it's low frequency, high wavelength, like ultrasound, but visible light, and then it reflects back from the various tissues of the retina, and by removing scatter from the reflected light, you can get a picture of the layers of the retina down to a cellular level. So you get a really high resolution image, which can be 3D. You can create a 3D image, much like an ultrasound, but it's using light rather than ultrasound. So we generate a really great image in depth of the retina, and it gives us a lot more information as far as leak goes. So it has revolutionized the management of diabetes by giving us that further information.
So yeah, I think if we look at the next slide, that gives us a good better idea of what you're saying there. So I remember you were telling me that, so with the fundoscopy, which is kind of what you'd see on that top left image, that's like a 2-dimensional image. But now, if you look at that line in the middle, that sort of aqua line in the middle of the fundoscopy, we're looking at a 3D image of that line. So we're going from 2D to 3D.
Yeah. So, sorry, Peter, did you want
to go on? Yep.
Well, if you look at the fundus image, there's very little diabetic retinopathy to be seen. It looks fine. And however, when you look at the cross section, which is the bottom picture with the labels, so that's looking at the retina in cross section through that line, which is going through the macula. So it's going through the macula and the disc, and we're getting a cross section, and it's giving us an assessment of thickening and swelling. So referring at the picture with the labels, the top of the picture is the vitreous, the dark space. And then we get a strip of gray tissue, which is the retina in all its layers, from the vitreous down to the choroid, which is deep to the retina. So those black spaces present within the retina is fluid, and it's localized in the center of the macula, and it will be having implications for the vision that are really not apparent when you look at the fundus photograph. And similarly, looking down the slit lamp, examining the fundus on the slit lamp, you'd be hard pressed to see that level of edema. So the OCT gives you that information.
So do you think this person would have visual loss at this stage?
Yes.
Yeah. So, and in terms of the sort of timeline looking towards the neoproliferative part of the disease, the edema comes before that. That's correct?
Often way before. Yeah.
So that's the other advantage. Yeah, like you were saying, it's able to pick up really early disease. Yeah, it's pretty cool. I never thought about that concept of being like an ultrasound of the eye. I think that's I'm gonna stick with that one. That's not a bad way to describe it to the patient. So I mean, I've had an OCT in my eyes when I've gone to the optometrist. I can't even remember what it felt like. I remember when they did it. Maybe like do you actually know when they're doing it, or is it just a...
Yeah, it's a red light. You're looking down a screen.
Red light, that's right.
Red light sort of zigzagging across in front of your vision, and that's the near infrared light. That's
I do remember that. I do remember that now, because that red light actually is a bit unpleasant. But it's fairly brief. Yeah,
it's very brief. Most patients can handle it, but it can be a little bit disconcerting, I think, sitting there in one place. While the light shines in your eye. Yeah,
okay. Well, that's good. So, look, if you got any questions about OCT, then just put them in the panel, because it's really important that you walk away and you understand this, and the fact that many of the optometrists have got this machine on hand to pick up these early changes. So we're going to get on to screening in a sec, but to try and understand screening, you kind of need to understand how quickly retinopathy starts with diabetes. So tell us about this slide here.
I think one of the biggest risk factors for diabetic retinopathy in diabetes is the duration of diabetes, and large population studies have established that after a type 1 diabetic, after 5 years, 25% of them will have diabetic retinopathy. After 10 years, 60% of them will have diabetic retinopathy. And after 15 years, and we've all got plenty of patients in our practice which we've been seeing for 15 years, and sometimes it sneaks up on us that they've been diabetic for 15 years, but 80% of them, the majority, have a form of diabetic retinopathy of some description. So it'd be rare not to have any signs after 15 years. But the key, I think, is at 20 years, 50% of people need treatment for proliferative diabetic retinopathy. So it's a 50-50 chance after 20 years that you're going to need treatment of your diabetic retinopathy, just due to the nature of the duration of the disease and the effects of the disease.
Yeah.
Um,
And when we talked about this, it just reminded us that the question to ask the patient when they're like as a GP when you're first meeting someone with type 1 diabetes is what age was it diagnosed? Like for your eyes, and as many of the complications of diabetes, that's the key, because then you can work out how long they've had it. And if you're meeting them for the first time when they're 25 and it was diagnosed at 15, then you've got to remind yourself that's already 10 years of potential risk to the eye.
mm, yeah.
Yeah. And then type 2 diabetes, the overall prevalence is about 1 in 3.
Yeah, type 2 is interesting because I think we're often guided in screening them. They've often had it for longer than before they were diagnosed. So as a matter of fact, I think sometimes the incidence of diabetic retinopathy can be slightly greater in type 2 than in type 1 because they've had it perhaps longer than before they were diagnosed. But in saying that, the prevalence of diabetic retinopathy is actually, in large population studies, is 50% less now than in old studies. And that's attributable to, I think, better control. There's, the medications are so much better. And I thought that was a very interesting fact that we're doing well. We're really doing well, I think, at reducing the incidence of this condition.
Yeah, great. And then so if we go to the next slide, these are the guidelines, which are there's been a slight change that you've highlighted there. So
yeah,
tell us about the guidelines here.
Well, on the left is the preferred practice patterns for diabetic retinopathy of 2019, and this may be very familiar to you. That 5 years after diagnosis of a type 1 diabetic, they need to be screened, and then yearly, in the absence of any diabetic retinopathy, a yearly screening. Type 2, you need to screen them at the time of diagnosis because of that fact that they may have been diabetic for a lot longer than before they were diagnosed. And similarly, they could be screened every year in the absence of diabetic retinopathy. Pregnancy is a risk factor for worsening of type 1 and type 2 diabetic retinopathy. So anyone who falls pregnant who's diabetic, it should be screened in the first trimester. And then every trimester, we generally like to see them every trimester. But gestational diabetes has been proven not to be a risk for the development of diabetic retinopathy, so we don't need to screen them. But last year, some RANSCO screening and referral pathway for diabetic retinopathy came out, and I thought there was just some minor sort of changes. They said that rather than 5 years after diagnosis, children need to be screened at puberty. So that is potentially a time of risk of the development of diabetic retinopathy. They said that, and this is crucial, that in the absence of other risk factors associated with diabetic retinopathy, like hypertension, hypercholesterolemia, we'll go through them. And if there's no retinopathy, you can screen every 2 years. And I think that's sort of predicated on that evidence that perhaps there's been a reduction in the incidence of diabetic retinopathy with better medical management of diabetic retinopathy. But yeah, I crucially stress that is in the absence of any other modifying risk factors. And I think that'd be pretty uncommon, that someone just has diabetes, but doesn't have hypertensive, doesn't have hypercholesterolemia. They still require a yearly review. So I think I'd be very wary of a 2-year screening protocol, but it's possible. And as far as pregnancy goes, I think the recommendations are much the same in the first trimester and in the presence of retinopathy every trimester, and not for gestational diabetes.
So the next slide's got those extra modifiers that would pull you back from 2 years to 1 year that you just started to talk about, like high blood pressure and cholesterol. So
Should we talk about all of them? Should we talk to all of them?
Yeah, highlight them. Yeah.
I think the duration we have mentioned before, over 15 years, they need regular screening. Anyone who has a long-standing poor control HbA1c greater than 8 certainly needs more regular review. Anyone with associated hypertension, abnormal lipids, cardiac disease, cerebrovascular disease, renal disease, peripheral neuropathy, peripheral vascular disease, or foot ulcer needs regular review. Pregnant patients we mentioned, and Aboriginal and Torres Strait Islander, of course, locally need an annual review, and other migrant populations too, which have also been shown to be at increased risk of diabetic retinopathy.
Yeah, so the way I've been thinking about that is think about those things like renal disease and peripheral vascular disease and foot ulcers, or they've had a stroke or they've had a heart attack. That sort of end organ, end peripheral vessel disease. So if they've got any end peripheral vessel end organ disease anywhere else in the body, just don't forget the eyes, whatever you do, because the same is going to be happening there potentially.
Absolutely.
That's how I'm thinking about that. And there was a question in the box here. Can you do OCT on children?
Yeah, absolutely. It's very non-invasive, and it's very quick. It takes a matter of minutes, and with a little bit of compliance, it's certainly quite doable. So
this next slide's highlighting the risk in our Aboriginal communities. I think that just goes to highlight, because all those other risk factors are making diabetic disease more common. It was interesting on that other slide too that they didn't have smoking, which I would have thought would have increased risk. Wouldn't it?
Yeah, it would. It wasn't in the RANS Code guidelines, but certainly would exacerbate it. Small vessel disease.
Yeah. So we'll move to the next slide. So just a quick word about AI, and then we're going to get on to laser and injections. So
good.
What's your feeling about AI, Niall? Are you going to be out of a job soon?
No, I don't think it's going to take off. It's got a lot of limitations, and there's been an FDA approved AI algorithm. It's IDXDR, and so basically all it's doing is it's establishing with a quick scan whether the patient needs to be referred to an ophthalmologist or whether they just need to return in 12 months. So it's purely in an effort to alleviate the burden of referral to an optometrist or an ophthalmologist. And the approved sort of device, it involves an expensive camera. It involves taking just a 45-degree digital image. I mean, we've got much wider field imaging available to us now, and I think the time it takes to develop all these things, the technology's moved on, and it's really outdated. And then so then it uploads the image, and then without the requirement for any human intervention, it establishes within 20 seconds whether they're fine or whether they need to go somewhere to be seen. It's not 100% sensitive and specific. It's got some limitations too. It's only 90%, and like I said, it's just a fundus camera. So it's not going to take off. It needs more work.
More work. It does look pretty cool though. Especially you can imagine when you're living very remotely how this could be beneficial. But I think it's great you put that slide in there. Something to think about for the future.
Yeah.
So once you've got diabetic retinopathy, the screening guidelines are far more intense.
Definitely. So I think this is due to the nature of the ability to treat these conditions. So I think when you've got severe non-proliferative diabetic retinopathy, but no diabetic macular edema, they're at very real risk of turning into a proliferative diabetic retinopathy problem with vitreous hemorrhage. And, there's a very high risk of that occurring. So they need, really close sort of monitoring. And it's not every year, it's every 3 or 4 months without fail. And then diabetic macular edema, as I say, it's amenable to treatment, and it can be quite visually degrading. And yet with treatment, it can be so successfully treated that you don't want to allow edema to sit in the retina for long periods of time. It'll have lasting effects on the retina. So if there's any indication of edema, we need to see them fairly closely too, up to every month. So once they develop any of these issues, they really go to another level as far as requiring monitoring. And the proliferative diabetic retinopathy, even in the absence of diabetic macular edema, it's an emergency that needs urgent treatment and follow up every 2 or 3 to 4 months because of the potential for requiring, other treatment and retreatment. And yeah.
And I remember you telling me, one of the things that helps you is for the GP or the optometrist or whoever's seeing the patient, the nurse, to reinforce the need to keep coming back to see you or your colleagues, because that does get quite intensive if you come back once a month for injections, but it's hugely important. So I think that's a message for us, is that once there is disease, and we're seeing these letters saying coming back for monthly injections, to just check in with the patient, encourage them, support them, because it's they're getting treatment that's going to save their vision.
The patients generally respond really well, I think, because they do notice a difference within 48 hours often to the treatment. So they are very appreciative, and they do appreciate the difference you make. But I think it's like anything, there's a lot of obstacles to patients returning for treatment, and the big issue often is their inability to comply for whatever reason. So the more we can aid in that, I think the better the outcomes will be.
The better, yeah. And someone's asking about, it can be a bit scary getting a needle in the eye. So we're going to talk about that in a second with the picture. So we're going to keep moving. So we've got about 20 minutes to go, Niall, and we want to get to the injection. So we are just going to quickly look at traditional treatments. So this is a laser that
it's a very portable laser. That's how, and laser, it can be delivered via the slit lamp. So you may not have seen one before.
Yep.
This is what it looks like.
That's what it looks like. And then the next image is what the eye looks like after laser.
Yeah, so this is after the laser. There's been quite a bit of laser uptake there. There's no fluid or blood. So this is a sort of long-term follow-up picture, but that's just an idea of where focal laser is done to macular edema around the macula.
Yep. And that one?
So that's another algorithm for doing macular laser for macular edema, and it's just a more sort of broad pattern of basically laser delivered in a grid pattern around the macula, not centrally. You notice there's no laser burns right in the center of the retina where the macula is. You'll cause lasting damage to the vision if you laser that, but it's around the macula in an effort to alleviate macular edema.
Mm-hmm. This is a pretty picture.
Yeah, so that's a pan retinal photocoagulation, so PRP. So you do about 2,000 laser shots to ischemic retina in the outside the retinal arcades. So naturally, you're avoiding the central retina, and that's in an effort for the treatment of proliferative diabetic retinopathy. So this, I can't see any. There might be some little new vessels at the disc there, but there's no hemorrhage or anything in the vitreous. So similarly, I think that that's probably a little bit down the track. Those laser burns are fairly well established.
Yeah, so that's more the traditional approach. So, and the next slide was just to highlight to everyone that there are about this rather large studies now going on, or there have been studies to compare laser versus the VEGF treatments.
Yeah, well, this first one really is, it's an old study, maybe 20 years old, I think, but I think it's very relevant to you guys in general practice, and that it proved that with intensive treatment, it delayed the onset of diabetic retinopathy. It slowed the progression to the development of early retinopathy. It reduced by 50% the risk of developing severe non-proliferative diabetic retinopathy and proliferative diabetic retinopathy, which is the sight-threatening types of retinopathy. The study showed that it decreased the requirement for laser. It reduced microalbuminuria and neuropathy in the people in the study. It did lead to more weight gain. I don't know. I think that's
probably from the insulin.
Yes.
Yeah.
Led to more frequent hypoglycemic episodes. Not unexpected, but that point about which you may not be familiar with, that if you're a badly controlled diabetic and then you're brought under very good control very quickly, we often see a worsening in the diabetic retinopathy. So it's very important that these patients are seen by their ophthalmologist at the time that you're bringing their previously poorly controlled diabetes under control, because they can go from a non-proliferative to a proliferative diabetic retinopathy really quickly within weeks, and can go on to develop vitreous hemorrhage and develop all the severe sight-threatening complications due to the nature of tightening of the blood sugar. So naturally, we encourage tightening blood sugar. We have no objection to people being tightly controlled, but we just need to be involved, I think, in managing them. And ophthalmologists have all seen cases where by bringing a patient under tighter blood sugar control, they've developed blinding complications of the course.
That's a really, really important point, one that I wasn't aware of. So thanks for highlighting that. Someone, just back with the laser, someone wanted to ask, what happens if you accidentally hit the, I think it's arcades with the laser?
Arcades. So that's the blood vessels arising from the disc, and you can cause bleeding. You can cause a hemorrhage, a retinal hemorrhage, an intraretinal hemorrhage. You can cause a vitreous hemorrhage.
Bad stuff.
It's bad, but not as bad. No, I don't think it's as bad as you might think. I think you can get away with it. I think you can just hit them, and I think you can get away with it, but best to avoid them. Yeah.
So you got to try and keep the eye still when you're doing laser.
Yeah, you hold the lens on their eye, so you do keep. Well, depend if you're doing it by the slit lamp. I use a lens which keeps the eye still, but you can certainly deliver a laser via an indirect approach, and it does require the patients to be still and looking in a certain direction. But you avoided the macula. You're really attempting to avoid the macula at all costs. You're very concerned about the disc and the macula. You can't afford to laser that.
Yeah. Okay. And then these are some other studies about the injections. That's right.
So it's a very long study, and I won't go through it. But this is where all the thinking and decision making around diabetic retinopathy treatment modalities is done now. It's a US, multiple sites in the US, and it's very recent, since 2002. And it's the one that's coming up with all the protocols for how best to treat laser versus the various types of anti-VEGF agents, and what's better, what's worse, which is superior, which is inferior.
Yeah.
Yeah.
So this is a slide you put together for us to think about the pros and cons of each treatment.
Yeah.
So that's really cool. Thanks for doing that. So tell us a little bit about how you think about this.
Yeah. So lasers, very traditional method of treatment, and anti-VEGF is more recent development. And laser was very effective for the treatment of proliferative diabetic retinopathy. It required maybe 1 to 4 sessions to complete the treatment. So it doesn't necessarily rely on ongoing compliance of the patient. You can do the treatment, and you don't need to necessarily follow up as closely as if you were just treating with an injection. And the effect is, effectively permanent. It's probably less reliant on the blood sugar control after the treatment's given. You're not necessarily at risk of developing sight-threatening complications. Once that laser's done, you've sort of ablated the ischemic retina, and you're not the patient's not as a greater risk of developing anti-VEGF and developing further new vessels. So, but on the downside of the laser is by treating the peripheral retina, you are potentially stimulating diabetic macular edema. So you need to be aware that you need, sometimes the vision, you can make the vision worse if you're not careful. And sometimes it's useful to perhaps treat the macular edema as well, or give an injection as well. It's painful, that laser, 2,000 shots. You can feel every one of those shots, so it is painful. Sometimes people require a block. Sometimes people need a general anesthetic if you want to do a complete PRP, both eyes at the one time. It does lead to lasting effects as far as night vision. You lose night vision, you lose some peripheral vision, you can lose accommodation. So if you're presbyopic, you'll bring on presbyopia. And the studies have shown that there's less sort of a visual acuity gain by doing that original type treatment with laser. Whereas the anti-VEGFs, which are fairly recent, maybe only in the last 10, 15 years, it works for diabetic. It'll solve the diabetic macular edema problem. It'll solve, or rather alleviate the proliferative diabetic retinopathy problem. It doesn't lead to any side effects as far as peripheral vision loss, doesn't affect the night vision, and the vision can actually be improved by the treatment. So, as you can see, it's really superseded, if you like, or rather added benefit to the treatment of diabetic retinopathy as opposed to the traditional laser. But the problem with anti-VEGF is the effect is only 1 month, maybe 2 months. And if the sugar is still poorly controlled, you'll go back to how you were before. So it's not a permanent effect. It's a very short-lived effect, and hence the compliance requirement for ongoing monitoring and ongoing regular sort of monitoring and regular injections. There's not necessarily a do one injection and then the problem's solved. It's definitely not. So it needs a lot of patient compliance.
Yeah, great. So we've got about 10 minutes left, Niall.
Okay.
So yep. So this is an injection. So
yeah.
So how do you tell someone? How do you prep someone that you're about to?
Yeah. Well,
is it making them a bit calmer and?
Yeah, I think you will have lots of patients in your practice that are having injections, and it can be quite, we do local anesthetic drops, and some of us do subconj local anesthetic. I do. It can be absolutely painless. Occasionally, people are very anxious, and I think it's sometimes impossible to necessarily to avoid, pain altogether. But I think this is a picture of a patient receiving it in theatre. But I showed you this picture because the patient's completely de-identified. But it's certainly done as an outpatient very commonly, and the injection is very brief, a matter of seconds. But at the same time, there's definitely risks associated with it, and we rely on a patient that doesn't move, and we can't afford patient movement and non-compliance, and there's a risk of infection too. So we've got to be wary of that.
And where's the medicine actually going in the eye? Is it just going to the vitreous? Is it?
It's going into the vitreous. So we inject via the pars plana, which is a part of the ciliary body. So there's the iris, which you're familiar with, and then the root of the iris then becomes the ciliary body, and then behind that is the pars plana, which is part of the ciliary body, and then the retina. So you can inject multiple times through the pars plana without inducing a retinal detachment. If you were to go through the retina, you would put a hole in the retina and cause a detachment. If you went through the lens, you'd cause a cataract. So it's you're literally threading the needle between the lens and
yeah, right. And you don't want to go in too far either, I'm guessing. You've got to
you point the needle at the optic nerve, and you can go in as far as you like. You won't get across you won't hit the optic nerve. I think it's possible, yeah.
No, got to have a steady hand, that's for sure.
Yeah.
Okay, so these are the drugs we're all familiar with. Are they all fair? I know there's a long-acting one, but these ones, they're
equally effective. I think they're pretty interchangeable, and they come in pre-filled syringes now. It's a very small volume, 0.05 of a mil is injected, so very, very small microscopic amounts, but it can put the pressure up in the eye. That's one of the potential problems, raised pressure. As well as a hemorrhage. I think we were saying very common. Your patients may get a hemorrhage, subconjunctival hemorrhage, not a big problem. Air, you can sometimes inject air into the eye, which is generally absorbed within about 6 hours, but patients sometimes have a little bubble, which is generally not a problem.
And then this is the long-acting one that lasts for 6 to 12 months, you were saying?
6 to 12 months. So this is only, it's a steroid, so it can only be given if there's a cataract operation is imminent, or at the time of a cataract operation. So because you'll induce a cataract with this injection, so it's not for everyone. They need to be looking at having a cataract within months, and then it's also a steroid, so it's at risk of putting the pressure up in the eye. So they need a little bit more monitoring for pressure. But I found in Aboriginal Torres Strait Island patients where they're not always as good with follow-up, I find that this is a very successful method of treatment. And sometimes they don't return for follow-up till 12 months later, and the diabetic retinopathy is gone. So I found it really quite useful in Aboriginal and Torres Strait patients.
Yeah, it's good to know there's a long-acting one. So we've got a few cases to finish up. So this is your case here. You tell us about this one.
So this is a 66-year-old Caucasian man who's been diabetic for 17 years. His long-term HbA1c is greater than 8. He's on metformin. He's on Lipitor. So he's got hypercholesterolemia in addition to non-insulin dependent diabetes. His vision in this eye that's shown on the OCT is 6/12. The picture shows very minimal non-proliferative diabetic retinopathy, top left, but the OCT shows macular edema. So that accounts for his reduced vision. So he was given an intravitreal injection of Eylea, which is a aflibercept, which is an anti-VEGF agent, 2 milligrams in 0.05 ml. At 1 month, he was given a further injection. And then 2 months after that, he was given a third injection. And his OCT after 3 months shows no macular edema remaining. That's the bottom slide. And his vision had improved from 6/12 to 6/9. So I think that's a great result.
Magical, yeah. Does he have to go on and have monthly injections or 3 monthly injections, or
no? So no, not for macular edema. So it would certainly be a case of monitoring him over 3 months, but there's quite possible that's the end of his intravitreal treatment. It's not like macular degeneration where the treatment is ongoing. This diabetic treatment has a beginning and potentially an end, so it's not an ongoing treatment.
Yeah. Yeah, great images. Thanks for that. So, and then we'll finish up with this one, which is a case of mine, who's a 30-year-old Aboriginal lady who's got a significant past history of gestational diabetes. So, age 22, 25, both requiring insulin, had a miscarriage requiring insulin, and but despite the diagnosis of diabetes after those pregnancies, openly admitted that she was in denial about this and had poor follow-up, partly for various reasons, but and she was a smoker, and in fact she'd seen Niall actually in 2018 and had been diagnosed with NPDR, but again had been, she comes to my practice, I'm putting my hand up here to show as an example of where we've missed something. Part of the reason why I missed in the last 12 months and felt terrible about this case when she actually went on to have serious eye disease was, she was coming to see me about a whole lot of other stuff, domestic violence, social and emotional issues. And, it's just so easy to forget this. And, she hadn't had the standard of care because she, the diagnosis was quite late after her pregnancies, but she clearly had diabetes for a very long time by the time she presented with this issue, which was last year. She presented to the emergency department with a headache and vomiting and a left eye which was blurred and red and watering. So beware the unilateral red eye. I do remember that from my medical student days, Niall. And she had a significant loss of vision in that eye, but no one in the ED unfortunately did a pressure and made the diagnosis of a cluster headache and sent her home. Fortunately, she came back 12 hours later saying, I'm no better. And one of your colleagues, one of the registrars, just to re-emphasise there are ophthalmology registrars at the base, reviewed her and her pressure was 62, which is phenomenal. I'd never seen that before. And she was immediately started off on multiple drops to get her pressures down. And the next day saw a colleague of Niall's and had something called neovascular glaucoma and high-risk PDR and macular edema, and went on to have a trabeculectomy. She had the pan-retinal phytocoagulation, which was that picture with all the lovely images we saw, the yellow dots in it. And then she went on to have monthly Eylea injections for the macular edema for 12 months, and her vision is now 6/7.5. So that's a really good case. She nearly went blind. I was shaking in my boots that I'd stuffed up and I hadn't done the screening, and but fortunately there's been not unreasonable outcome, and she's certainly taking her diabetes extremely seriously now. In fact, she's almost off her insulin, although she got pregnant again, had to go back on it, but she was doing pretty well, and her A1Cs are well under 7 now. So yeah, that's a tale, a warning tale. So there was one other question before we finish up. We're about 2 minutes over time, but just very quickly, someone asked earlier, so if you've got proliferative diabetic retinopathy involving the including the macular edema, do you do PRP, the pan-retinal stuff first, or do you go straight into the injections?
Well, there's a change. There's definitely a change in emphasis, and you definitely do an injection because you treat the macular edema first, because if you did PRP, you'd exacerbate that. And you could actually, there is two schools of thought, whether you just continue to do injections, and that would potentially solve the problem completely, but it would need ongoing monitoring, and it'd certainly rely on patient compliance, and then you'd avoid all the side effects of laser. But if you had a very non-compliant patient, you would definitely consider them for laser. Once you'd sort of given the injection first, solve the macular edema, you do the laser. Yeah, it still has a role. The laser definitely has a role.
All right, great. So we've got case 3. We don't have time for that, unfortunately. So yeah, look, just to highlight those things about the role as yourself as the GP or the optometrist or the nurse in helping reduce or improving management of their diabetes is going to reduce the risk of diabetic retinopathy. Remembering those guidelines and ensure that you are referring yearly or second yearly if they don't have any other risk factors. Remember about OCT, now you know what that is, the ultrasound of the eye, giving you a 3-dimensional image, picking up early signs of edema, and this massive change in the way we treat retinal disease with the increasing role of the anti-VEGF treatments and decreasing role of laser. Or we've got one last quick question. I will get one last in. Why is Ozurdex more likely to cause cataract? I think that was the long-acting steroid. That was a long-acting depot steroid.
The others are not steroids, so they don't lead to cataract formation. So that's one of their benefits. Whereas the Ozurdex is definitely steroid. Glaucoma and cataract is highly likely.
Great. Okay. So that's all we've got time for, unfortunately, Niall. We'll have to get you back and talk about macular degeneration, because it's clearly been a well-received topic. So thank you so much. If you could just stay on the line for 30 more seconds to remind you that you can certainly look at any of our previous webinars, or you can refer your friends to watch this webinar through the Nordox website, where you can see these will be recorded. This will be up there. Give us a few days to get it up there. And that our last webinar for the year, which will be in 4 weeks' time, we're going completely different to eyes. We're going to have a chat about the new brave new world of psychedelics with Dr. Bob Lodge. And when you log out of this Zoom, there'll be a brief survey and an opportunity to register for that next webinar. Thank you very much for attending tonight, and we'll hopefully see you in a month.